we first have our more early stage investigator who's going to first give a talk and introduce Elvin. So it's my privilege to introduce Dr. Hannah Leslie, who is an assistant professor in the Division of Prevention Science here. She's an epidemiologist by training and really works on the comparative assessment of health system quality, patient-reported measurement, and population preference assessment. And her work has spanned many areas, but right now she's going to talk to us about HIV prevention, young men accessing that in South Africa, and also works in Mississippi and other places around the world. So thank you so much, Hannah.
All right. Well, thanks everyone, and good morning. It's a pleasure to be here. So I will be speaking about men's preferences for accessing health services in rural South Africa. And first, I want to be sure to figure out the slides and then acknowledge all of the wonderful mentors, especially Dr. Lippman here at UCSF, and my collaborators on this work, and the research support from NIH and the CFAR here. And then the new project that I'll talk about is supported by Gilead Sciences. So all of the work that I'll be gosh, that was terrible. Sorry. You missed me thanking everyone for making this possible. So all the work I'll be speaking about today takes place in the Bushbuckridge municipality in rural Mpumalanga province in eastern South Africa. This is a wonderful research site because there's been a census and demographic surveillance system in place for over 30 years. Which has really yielded extremely valuable insights around health and well-being for this population. The research site spans a quite rural area that is served primarily by government health clinics and health centers, and where HIV has been a really critical concern, for several decades now. The area was an apartheid era homeland, and so there's extreme resource deprivation and very limited employment, which has shaped patterns like circular migration to the cities for work, which can also fuel overlapping and concurrent partnerships. And there's also frequent age discordant relationships with young women having relationships with older men. And so you can see here in the last comprehensive prevalence study is actually data from 2010, but I think still relevant. And you can see the very sharp prevalence curves for young women. Adolescent girls and young women are a major priority population for HIV prevention because, as you see, prevalence is getting into the 30s by the time women reach their mid-20s. And then I think it's also really critical to look at the young men here. So by the time men were in their 30s when this prevalence snapshot was taken, 2 in 5 were living with HIV. And that's over a quadruple the prevalence that you saw in men in their early 20s. So this is a really key population group, largely fueled by heterosexual transmission, that has not been as much of a priority of the health service outreach. So in this setting, government primary care is really the main health service option. This is data from a survey that we did 5 years ago. And you can see in those top 2 clusters of bars that health centers and health clinics are used by the majority of people. The darker bars in blue are for women and men are red, and the darker bar is the usual source of care. So the plurality of individuals were relying on health centers, which are slightly larger clinics, and then the small clinics themselves as their usual source of care. And you can see that men were a little bit less likely to use health centers than women. And then you can see when you look at the more lightly shaded bars, HIV testing was a little bit less likely to happen in those government primary care centers, particularly for men who often looked elsewhere for HIV testing in that bottom bar, even though there's actually relatively few private care providers, not very many pharmacies in this that are accessible within this area. And at the time and still today, pretty limited self-testing. But these primary care clinics are really a space for women, traditionally. They're staffed by nurses who are overwhelmingly women. We did a clinic quality assessment where we were randomly sampling patients on exit and excluded those who were there for their children. 94% were women. And the male patients who we were able to speak to were a little bit more likely to report experiencing some discomfort during their clinical care, feeling uncomfortable. And I think it's important to recognize that because women are interacting with the healthcare system routinely for care for their children and for reproductive health services, even though there are certainly ways the health system can be better in meeting women's preferences, that men are making more selective decisions about accessing care. And I think we see evidence that their behaviors are more influenced by their perceptions of the care available to them. So we found in our survey results that men who were confident in their usual source of care, who felt they could receive high quality care, were more likely to report a recent HIV test, where we didn't see this association for women. And on the right side, you see the decisions broken down by the individual clinics and centers. So the red bars are people who chose not to go to their usual source of care for their HIV test. They wanted to go somewhere else. These are the proportions for women, and these are for men. So again, you can see men are more likely to be making active decision-making about where to go for their care. So how the services are delivered is even more important in reaching this population that is less likely to be caught sort of during routine, regular visits to the health system. And then we combine these survey data with clinic data, and we actually found that the current access to preventive behaviors like HIV testing may be even worse than we thought, because we looked at if individuals had reported a recent HIV test, and we tried to link that report to the clinic data that we had access to thanks to the longstanding research collaborations. And we could only connect about a third of reported recent tests to a clinical record documenting that that test had taken place. And we know that there is under documentation in the clinics, particularly of negative test results. So we tried to account for that and increase our estimates. But even with that, we found that particularly for men, there was a threefold disparity between the prevalence of self-reported testing and how many people we could confirm and with our corrective factors estimate had really had a test. So that from the survey, you would think about half of men not known to be living with HIV had gotten tested in the past year. From our confirmation of exercise, we think it's closer to 15%. So when you put these things together, the role of trust in the health system, the limited routine use of care, and then minimal outreach to this population, it's not surprising that we've seen minimal PrEP uptake among young men. So right now, oral PrEP is available and approved for all at-risk adults in South Africa. It was rolled out in a staggered fashion with priority to sex workers, men who have sex with men, and adolescent girls and young women. And that initial rollout has still shaped the uptake that we see today. So again, the men are in red here, and you see across Bushbuckridge with its population of over 500,000, numbers in the low hundreds in terms of ever starting PrEP and remaining on PrEP. So that brings me to a study that I'm really excited to get started on right now, which is that we want to try to figure out, given that we have limited resources, we need to reach men with preventive options. What are the priorities for meeting men where they are and meeting their preferences for health services? So we'll be doing a discrete choice experiment on PrEP delivery models for men aged 18 to 30. Starting with qualitative work to understand how men have access services or would consider access services, and also speaking with providers in the Department of Health. There have been attempts to implement men's clinics and other outreach efforts in the past, so learning from what's already been put in place and what could be put in place. To really design and test our discrete choice experiment around some of the pieces that we could potentially improve on: the information sources, the pickup points, the social support or peer information networks that are happening, what kind of provider they're seeing, what times of day or where they're going. So all of the pieces around the different PrEP products that are currently available or that may be available in the future that could make it more convenient, more trustworthy, less stigmatized, easier for men to access HIV testing and PrEP. So hopefully I will be back in a year or two to tell you more about that study. So thank you very much. All right. All right, it's my pleasure now to introduce Dr. Gang, who probably needs no introduction at UCSF, but he's a professor of medicine in the Division of Infectious Diseases in the Department of Medicine and director of the Center for Dissemination and Implementation at the Institute for Public Health at the Washington University in St. Louis. He is an MD and MPH from Columbia and did his fellowship here in infectious diseases. Sure. And his work uses implementation science to conduct research to optimize the use of evidence-based interventions with a focus on HIV. It takes place in Kenya, Zambia, Uganda, and safety net settings in the US. And he's also in an editorial role for PLOS Medicine, the Journal of the International AIDS Society, Implementation Research and Practice, and current HIV/AIDS reports. So send him all your pending papers. Thanks.
Good morning. Good to be here. Thanks for having me. I feel honored to be here, and it's a real pleasure to have a chance to talk with folks that I have known well, and some new faces as well, after having been away for some time. But yeah, I definitely feel like in some ways I was here this morning. I'm staying at a friend's, went to the corner to get some coffee. And in many ways, I felt like I've been in a time warp, because it very much does feel like home, as does this room. So I think I have about a half an hour today. Is that right, Monica? And we'll just give. Okay. All right. Sounds good. Okay. So I think I was just going to take this opportunity to give people some of my current thoughts, provisional and in the process of being baked, about implementation science and its role in the scientific HIV response. And this has been a topic of a lot of discussion and something that I've been thinking about, but wanted to pressure test some of these emerging ideas with this group. So the kind of outline here is that, I think it's become clear, I think, to almost everybody, that going the distance in the HIV epidemic, bringing the epidemic to sort of a close as a public health threat, involves improving implementation. We have the tools for this work, and we need to use it to improve population health. Implementation research offers novel and innovative means for advancing implementation systematically. And I think that case has also been made over the last decade quite clearly, and is sort of an emerging consensus. But I want to talk today a little bit about what I think its promises and its perils as well. So will implementation science really elevate the scientific response, or will it get in the way? And I think that the answer to that question is still coming into focus. I'm going to give you some ideas about what I think its contributions could be and how I think it might get in the way, and then close with some thoughts about how we can manage the scientific environment to make sure we make the most out of it and not let not let it get in the way where it could. I have 4 sections that I've titled here in this talk, that starts with chicken sandwiches and ends with social epistemology. So hang tight. All right, the scientific zeitgeist. So this is going to be about chicken sandwiches first. So you've heard this case before. Let me see. Oops, got some. So some PowerPoint issues, but implementation science has been offered up, and I've been part of this as a way of improving the HIV response. So if you'll indulge in a little bit of nerd humor here, this is an equation, and it says that basically impact is a function of implementation research, the investments in the HIV response, and the efficacious interventions that we have, and the interaction between these things. And I'm arguing that beta 4 here is a major factor, because the investment envelope is not going to change. The efficacious tools, we have many, we will have more, but we have already many. And implementation science on its own isn't going to do a lot without its interaction with the other things. So I think that the promise is that implementation science will make what we have at our disposal even better. And in HIV in particular, there have been a lot of sort of calls to action in this space. Here are a number of commentaries, some of which I'm guilty of writing, that advocate this position, that say implementation science is the way forward. There's a piece in JIS, and then there's a piece I wrote with Enola Proctor in Science this last year, calling for the NIH to spend 10% of its budget on implementation science. And I think that there has been some sort of drinking of the Kool-Aid. I wasn't aware of these animations, but there they are. This is from NIH Reporter. This is the amount of money that NIH is spending on implementation research each year. And over the last 10 years, it's gone from about 200 million to nearly $1.5 billion. So somebody somewhere is drinking the Kool-Aid. This has risen in particular sort of sharply since 2019. And I think that this will continue to grow. So it's now part of the landscape. NIH has, I think, a $45 billion annual budget. So this isn't an enormous piece of spending, but neither is it totally insignificant. It is the product of, I think, intentional investment in this area. So is all that glitters gold? I think the HIV research enterprise has been very successful, and scientific change takes time, energy, and effort. On the one hand, I think the premise is clear. The case for implementation science is clear, but on the other hand, I think that the scientific community and myself as well also have doubts about it. So is implementation science adequately rigorous? Is implementation itself scienceable? If I could use that term, some people have felt that it's too chaotic to bring into a scientific process. And then what the heck are all these frameworks about anyway? So I am using the chicken sandwich to illustrate, I think, this dilemma, which I'm calling scientific prospecting in a time of uncertainty. So at a moment when science is maybe shifting, and there are new methods and new perspectives, and new sort of centers of gravity in the thought. And I do think this is true. It's interesting. Many people here at UCSF are on study section for the behaviorally oriented HIV study sections. And, I've definitely noticed over the last 5 years that the predominance of proposals have shifted from sort of behavioral science to implementation science. I mean, for the PPAH, it's almost 100% implementation science from what I can see these days. So there has been this shift, and so do we invest in sort of these new ideas as a scientific community? This question of sort of scientific prospecting is formalized in the explore-exploit dilemma that people have written about, and I talk about it oftentimes using the chicken sandwich problem, which is if you go to lunch every day and you go to a sandwich shop and you get the chicken sandwich and the chicken sandwich is really good, at what point do you look on the menu and you see that wasabi beef sandwich and you say, okay, I'm going to try that wasabi beef? Because if you don't try it, you know that you have the chicken sandwich and you know that it's good. But if you don't try the wasabi beef, you'll never know whether or not it was better. But you could win or lose, right? You get the wasabi beef and it's awful and you've wasted your chance to have another chicken sandwich and the money as well. But on the other hand, maybe you found a new favorite sandwich. So I think that this is navigating or prospecting sort of new ways of looking at things is one of the ways in which I see kind of the scientific maybe zeitgeist of many fields, including HIV. Okay, so what might we find in our prospecting? So here's, I think I have 3 sort of ideas about the promise, and then 3 sort of ideas about the perils. Okay, so in terms of the promise here, I think the original premise of implementation research is still a valid and important one, and maybe one that requires additional sort of work to fully flesh out. But the original premise is basically that the messy stuff done in the real world to use evidence-based interventions has to be examined scientifically. And I think that is still unquestionably the value proposition of the field. And I think in many ways it applies to HIV as much or more than almost any other field, in part because we do have such efficacious biomedical interventions. Obviously other fields do too. cancer, cardiovascular disease, but many of the fields, mental health and nutrition or other things are working with interventions that have far fewer clearly efficacious interventions than we do. So what does it take to put that complex, chaotic implementation process into sort of center stage? I think this has to do with three things. So one is seeing implementation, those activities, those functions, those actions that are used to translate strategic intentions into practice environments as a scientific target. So seeing those things as science is a shift. And I think that it's still a shift that is sort of in progress, but needs additional attention. It means seeing a class of treatments that is specific for implementation. So the idea of an implementation strategy is that it is a form of a treatment, and it needs to be seen with the same kind of rigor that a medical treatment, an injection or a pill. And it needs to be understood in terms of its immediate effects, which are referred to as implementation outcomes. So if there's an implementation treatment or a strategy, then what are its effects sort of most proximally? And I think seeing our problems through that relatively simple lens centers the idea of implementation as a sort of an area of investigation. Maybe more interesting is what happens when we don't center implementation science as when we look at questions of implementation. And I feel like I see a fair amount of this in the research world, and I'm going to use an example actually from Falls research or geriatric research. But research that takes control over the implementing process in the real world is often sort of referred to as effectiveness research, right? So you do something in the real world, but the researchers maintain control over the delivery of what is being done. But in my opinion, effectiveness research doesn't really exist. There's always an implementation strategy. There's always something that's being done in a coordinated, systematic way to do something in the real world. And if you bury it, it's effectiveness research. But if you bring it to the surface, it's implementation research, because that is, you now have taken your treatment and made it transparent. And that gives you something, I think, to clearly understand in a scientific way. So I think that there's many opportunities to advance that kind of thinking in the empiric research that we do. And when we don't do that, oftentimes maybe there are opportunities to learn that are not sort of exploited. And I'll use this as an example. In some ways, this paper is also an example of where implementation science is at. So this is, I'm not. Are people here? Is anybody familiar with this study? So this is in the New England Journal. It's a randomized trial of a set of implementation of a set of evidence-based interventions to prevent falls. Okay, so there have been over 250 randomized trials of interventions to prevent falls and a dozen meta-analyses and network meta-analyses to identify efficacious interventions. And there's like 7 interventions that are unequivocally efficacious. And I was reading this last night. I came up with an acronym for them because I don't remember, but I came up with SF Home because it's like, okay, now I'm going to fail my own test because I don't remember what those things stand for, but it's things like assess the home environment, test strength, assess medications, right? Make sure they're not on medications they're going to get them fall. Look at footwear, et cetera. So there's 7 things that everybody agrees. These are things that you need to do to prevent people from falling. And they've been shown in, trial after trial. So in this study, this is a PCORI funded study. It's a so-called pragmatic trial. My understanding from talking to some people who have been involved in this is that it cost $100 million. It's at 80 centers, involved several thousand patients, and people were randomized to 2 interventions. So one, the treatment was a nurse-led individual assessment and tailoring of those 7 things to the patient to prevent them from falling. And the other arm was like a pamphlet, like you get a pamphlet that says, don't do these things or you'll fall. The study, the way it was designed was that the nurse was part of the study team, and the nurse was supposed to communicate with the families and the patients as well as the primary care providers to sort things out. But and this this study was reported a couple of years ago in the New England Journal. There was no effect on falls. Okay, so it was purportedly a negative study. But if you read the study protocol and you read this study in detail, there's nothing reported. There's nothing conceptualized or reported between the nurse-led approach and the falls. And the implementation of all of those things is a complete black box. And it's a black box in part because I think the study conceived of that as part of the study intervention. And so there's a protocol for it. But at the same time, we're left with a very confusing set of conclusions, right? You have 7 evidence-based things. You try to give them to people and you have no effect. So one possibility is that those things don't actually work, even though there's over 250 randomized trials that show that they do work. The other possibility is that the real problem lay with the implementation of all those things, the coordination between the nurse and the primary care physician. Like you say, stop the benzo, the primary says, no, I can't stop the benzo. The interaction between the caregivers and the nurses say, you gotta get them to stop wearing, like, I don't know, some kind of shoe that makes them fall. And the family is like, he likes wearing that one. So the behavior change of the providers, of the dyads, of the families and of the patients themselves in this process, in the treatments it would take to change those behaviors were not part of the scientific sort of lens. And therefore, in my opinion, you've lost an ability to understand something, I think, kind of important. And these are important investments. So that's point 1. Okay, 10:02. I'm gonna have to speed this up a little bit. Point 2. So I think this is an interesting one, and I've struggled particularly it's taken some time for me to, I think, understand this, but implementation science does demand a new fund of knowledge. And it is, I think there's no way sort of around this. This is one example of this. This is The Diffusion of Innovations, written by Everett Rogers. It's the second most cited book. It's the second most cited scientific document. It's cited more than Watson and Crick's publication of the structure of DNA. And it is pervasive in a number of fields today. But this is sort of written in the 60s, a forerunner of implementation research. And I think that this is an example of a canonical piece of research that if we're interested in implementation, we need to know something about. In my next slide, I have an example of many different kinds of sort of ideas that are relevant for behavior and behavioral change in implementation, that run the range from individuals to relationships to systems to society. We don't have to be expert in all these things. Indeed, I think nobody can be, but at the same time, we can't avoid knowing enough about one or more of these things to be conversant of them if we want to be relatively seriously involved in understanding implementation. Okay, so that's the second thing I think implementation science asks maybe the applied fields to do that's important. The third is going to be around this idea of theorizing and conceptualization. And I think that the implementation problem is in many ways what I think I might call a wicked problem, where the problem is understanding the problem itself. That's a term written by urban planners at UC Berkeley probably 20 or 30 years ago. But there's a class of problems where we don't have the conceptual basis to understand and solve those problems. And I think that's very different than how maybe clinical medicine operates, because we do have such a strong foundation of knowledge about clinical medicine and biology. So a lot of what needs to be done, and I think implementation science pushes the field to do this, is to think about ways of conceptualizing the problems that we work with. And I think that this is a thread that we collectively as a field, if we were to emphasize and invest in, would yield fruit. And I'll give you some examples of this actually in the next slide. Let me see if so a lot of this, there's a couple of papers, including one here from Carol, who is obviously at UCSF and that you all know well. But I think that these types of papers, sort of redemption of the spoiled identity from Carol Camlin, What's Love Got to Do with It, from Norma Ware, which is a paper about how the relationship dynamics influence PrEP use in serodiscordant couples, right? And this other paper by Karen Webb and others in Zimbabwe, which isn't in the HIV field, but I think is very important, advance how we conceptualize problems in implementation. And even though they aren't sort of randomized trials, I think that they are critical for taking our scientific understanding of the implementation problem forward. The paper by Karen Webb is a very interesting paper, and I'll just say a quick word about it because I think it's so useful. You know, in Zimbabwe, in many places, the public health system has really championed it and emphasized supervised delivery. So women through village health workers are supposed to go to facilities and supposed to deliver. And there's a big public health push to do this, obviously, because assist or supervised delivery is associated with lower maternal mortality. And what she found was that the way that systems the way that this plays out when you don't have adequate health systems is that oftentimes the burden of getting to the facility falls onto the women, particularly the women that are the most vulnerable and who end up struggling to go to the facility and delivering en route to the facility, even though they know they can't get there because they know they'll be stigmatized if they don't deliver at the facility. So it places their lives at risk. It places the lives of the babies at risk, and it unfairly places the burden on the people with the least power. And I think that this kind of conceptualization of the unanticipated and adverse consequences of an implementation approach, right? I mean, everybody would agree that there's evidence about facility-based delivery, and therefore we should do something to help people deliver in facilities, needs to be continuously sort of examined and looked at. Okay, so I think that those are sort of three areas that I think are important for applied implementation research. Okay, now I'll do three things that I think are potentially perils. So this might be more fun. So one is, I think it's important that for the HIV field and its involvement in implementation science, that the field lead with the substantive science and think of the implementation research as a means to an ends, and position it to help us solve our problems, but not to define them. And I say this in part because there is a lot of emphasis on many of these ideas in implementation research that I feel like if we spend all of our time trying to sort out the nuances between Parihis and CIFAR and knowledge translation action frameworks, that we lose sight of the important questions and end up having the sort of tail wag the dog. And sometimes I think I do see that in proposals where, it seems like the science is justified by the framework that's being applied to it. So here's CIFAR, and then here's something we can do with CIFAR, rather than what the substantive issue is, and then what can we use some of these ideas to help us solve. Sorry, I'm using acronyms that I realize that people may not all be familiar with. this is actually just taken from UNAIDS data on the website, and it's kind of the cascade or the 1990s kind of retooled, so that the blue is over time the number of people that are undiagnosed and therefore need testing. The yellow are the people that are diagnosed but not on treatment and need treatment initiation, and the orange is people who have ever started treatment and therefore need retention type interventions. And this kind of epidemic evolution is what defines what we need to do in the implementation response. And looking towards the future, to me, it's very clear that the emphasis of implementation activities has shifted from sort of testing to longer term issues regarding retention and things like that. So these fundamental epidemic dynamics should drive our scientific agenda and how implementation is used in that regard. Okay, yeah, just a few more words on that. Integration of services, for example, horizontalization, quality. These are all things that, where we are in the epidemic response, tell us need implementation attention. Okay, so number two, this one, you know, I feel I oftentimes am involved in kind of the scientific sort of discussions around where implementation science is. I also find myself often a critic of it, and one of the ways in which I think the field needs to, well, one of the criticisms I have of the field is that I think it's cookie dough and not Chips Ahoy, if you will. It's still being baked, and it's a work in progress. So none of the ideas I think that are oftentimes promoted in implementation science are definitive and the last word on the issue. So in ERIC, which was done by my colleague Byron Powell, is a compendium of implementation strategies. It's very good, but it's by no means definitive, and by no means is concept mapping, which is the way that it was derived, a definitive method for establishing and categorizing strategies. And I think everybody I think, you know, Byron very much agrees with that. But I think that the field oftentimes takes those things and treats them as if, oh, this is like Goodman and Gilman for implementation science. It's like, these are the treatments. And it's not. I think many of the frameworks can be superficial. I probably didn't edit this slide enough. I'm not trying to call out any particular framework, but these are ways to get us started, but they are not necessarily sort of in and of themselves the answer to the questions that we want. I'm going to take an extra moment to harp on the concept of acceptability. Sort of the notion of acceptability, if you dabble in implementation science or if you've taken a deep dive, is everywhere, right? Everything's got acceptability. You send something to study section, they're going to ask you about acceptability. There are a few instruments that measure acceptability and feasibility. One of them is the AIM, FIM from Wiener and all. But despite its prevalence, is acceptability really what we're after here? Is it needed for implementation science, and is it sufficient? Is it needed for implementation, and is it sufficient? And I think the answer is no. It's not a fully baked concept, and it needs to be critiqued and sort of baked longer. Acceptability does not account for power and positionality, the most important element of acceptability. As my colleague, who is an academic but also a gay Black man, has said, I've accepted a lot of shit in my life, which is a statement about what acceptability means to people. It doesn't mean that you want to do it. It could be just a reflection of where you're at and who's asking you to do what. I think that the concept of utility optimization or maximization is another way of understanding acceptability, right? Because acceptability, feasibility, appropriateness, and these kinds of ideas are often thought of as properties of related to a thing, an intervention or a strategy. But in reality, how much you want something is not a feature of a thing. It's a feature of the other things that you have to choose from, right? And there are constructs like utility maximization in economics that account for that, whereas concepts like acceptability do not. The best example of this is, when you unsubscribe from like something, I get unsubscribed. They always say, okay, why are you unsubscribing? You didn't like my email enough. My email wasn't relevant to what you want enough. My email wasn't, like pretty and graphically designed well enough. And the truth is, it has nothing to do with any of those things. It's because I get too much garbage in my inbox. You could craft the most pristine, perfect email in the world, I will still unsubscribe from that email. So it's all about the other things that are around it. There's a story in Buddhism about the raft, and so in the story, a person takes a raft to get across the river, but when you get across the river, you don't drag the raft down the road because to continue your journey. And I think the notions of things like acceptability and feasibility are like rafts. They got us to a certain place, but the way where the field is at today, I don't think we can be satisfied with those constructs, and we have to look beyond them to make progress. Okay. Finally, this is the third and last, and I'll wrap up after this. I think that to engage in implementation as a science, we should be looking to social, psychological, and other theory beyond frameworks. And I think that sometimes the frameworks and models given in implementation science foreclose on the theoretical basis of the scientific questions early. So I think those kinds of discussions need to go on, and they also need to be applied to the work that we do. There are lots of concepts that are not well represented in the implementation science conversation that I think are really important, particularly in the HIV response and particularly globally. One, I'm calling butterfly effects, right? That's from this idea that there's a chaos theory idea that when a butterfly flaps its wings in Brazil, you get a hurricane in France, and there are these unanticipated effects that can't be anticipated from things, and we need to flesh out sort of what that means for the scientific activities that we do. Alignment. So does a strategy align with workflows? Polyfunctionality. We talk about strategies for implementation of evidence-based interventions. We can't possibly have a strategy for every single evidence-based intervention. There needs to be strategies that lift all the boats for the implementation strategies that we care about. So I think that if we think that implementation science ends with the commonly used frameworks, I think that's perhaps one way in which it can get in the way. So I think that would like to save a little bit of time for discussion. So let me just bring us maybe to a little bit of a closing. How do we make the most of implementation science for the HIV response? So what is the way forward? And for this, I'm gonna borrow from Sandra Harding and this idea of strong objectivity. So in my role at WashU, one of the things I do, or I try to do, is to sort of shepherd and convene the conversation around implementation science. And so there are sort of many different ways you can do that, right? You can do that through seminars, you can do that workshops, but I found some of these ideas from social epistemology, which is the study of the nature, origin, and scope of knowledge, to be very useful. So that's epistemology. Social epistemology is the idea that those things are embedded in who you are, and your positionality. So Sandra Harding is a feminist philosopher of science, and her dilemma, her question was, if science is objective, then why does science produce racialized answers? Why does science produce male-centric answers over time if it's an objective process? And her answer to that is that objectivity is not the property of an individual investigator. So she calls that weak objectivity, but rather strong objectivity is an epistemic property of a social system. So if a social system producing science is, in her critique, white and male, it will produce white and male-centric science. If a social system that produces science is diverse, it will produce a more balanced and more objective forms of knowing. She calls that strong objectivity. So this is a reorientation of what we think of as scientific accomplishment that has major implications for how we go about organizing the scientific conversation. So she says science is a social accomplishment. It's done collectively, but it also means that differences in that system is a means or a mechanism for scientific progress. I was going to end this with a training program that we do, and some of the folks here have been a part of this. Matt, Andrew, we've had a few other folks from UCSF, Kieran, and I think maybe one or two others. But at any rate, this is a training program in implementation science, and I think that it's positioned to be different. Well, it's positioned to be to invite people, not necessarily so much to learn about implementation science, but also to invite them to contribute to building the sort of foundation, building, rebuilding, revising, and critiquing the ideas in the field to make it sort of better. Maybe let me end there. Just some thoughts. This is my concluding slide. This is the Gardner hype cycle. So with any new innovation, whether you think implementation science is an innovation or not, it's an open question, but whether it's AI, social media, or whatever else, there's this innovation, and then there's this peak of inflated expectations when everybody thinks it's going to solve our problems. We're very much in that with AI right now. I think everybody thinks AI is going to solve our problems. I think then there's the trough of disillusionment when you realize that it's not going to solve all your problems, and eventually you end up in a plateau of productivity where innovations actually find a place where they can contribute the most. And I think I would like to think that implementation science is in this sort of slope of enlightenment phase, and that people who are involved in using it will also be the ones that find the best places for it to contribute and create value. I'm going to end there. Just some semi-baked thoughts about implementation science and the HIV response. I look forward to talking to people about it more.
Well, thank you so much, Elvin. That was great. That actually really helped me understand something that isn't complete. Do this work.
Yeah.
And I think for those who don't use this methodology, it can seem sometimes the frameworks can seem overwhelming, and so can the terminology. I guess my question was around the End the HIV Epidemic initiative, and whether you think that and the UNAIDS goals are essentially saying, take what we already know, but make them work through implementation. And do you think that that's why, I know you just showed the NIH implementation science funding going up in general, but do you think that's why possibly the HIV implementation science funding has gone up at the NIH, or has it been advocacy from other quarters but EHE?
I'm not sure I caught all of that. Monica, but I think that like there is definitely this interest in implementation science for HIV at the NIH, right? The EHE things. There's a bunch of coordinating centers that run trainings on implementation research, and I think like we don't have one of those at WashU in part because we don't have a CFAR, but we are I'm involved in a number of those, and I'm not part of this conversation is a little bit of a sort of a reaction to in my involvement in many of the sort of trainings around implementation science. I think that in a word, I think that we should be clear what is cookie dough and what is cake. And I think that some of the work in implementation science trainings is like, here's a cookie cutter approach and you need to follow this approach. If you follow this approach, you'll produce good implementation science. I'm skeptical of that. But there's money behind it.
Hey, Alvin, that was great. So you gave that example of that very large $100 million trial fall prevention and gave a great critique of that. And I'm thinking of someone who doesn't do implementation science, well, how would Elvin have spent those $100 million? Can you give us some insight? Because it seems to me that you have like, so there are some, ultimately you're after implementation of effective interventions and behavior change. And I can see that there are probably some common pathways, like, getting physicians to get rid of the benzo. There are probably common strategies that would be useful for many physicians, but figuring out how to get grandpa to, choose a different pair of shoes, that may be a very individualistic, one person may have a different preference from another, and the process to get them to change may be very different. So how do you focus in on the sort of the more common? Is that clear?
Yeah.
There are going to be some common interventions versus the very specific interventions that are going to be context dependent that may not have as broad an impact.
Yeah, I haven't thought like as much about the grandpa's shoes. But that's an interesting implementation question. Sort of how you work with behavior change with people that are, I don't know, maybe in a role where at a stage in life where autonomy is perhaps like somewhat limited and things like that. But I think so. I think what I just to try and give an answer to your question, and I'm not, it's always easy to play Monday morning quarterback, but looking at that, I would say, what are the implementation questions that we don't know the answer to, right? So if you have a nurse-led model, which is potentially a generalizable model, let's say you have a nurse-led model that coordinates a number of different interventions focused on fall prevention. The first question is, how do you ensure that there's rapport between the nurse and the primary care physicians? And I think that the field of knowledge translation, the field of practice facilitation, and other things, there are scientific insights there. It's like who you are, what's your identity, how do you establish rapport, what's the leadership's opinion about you, and then how do you gain credibility in the social system of the primary care docs? Because without further research, it could easily be that the nurses like sent a letter to the primary care docs, and the primary care docs is like, who is this? I don't believe your assessment. And by the way, I'm just going to ignore you because I don't know you anyway. So that engagement is a potential target for science. The same thing with the provider behavior. One of my favorite studies when I read this many years ago was from the NHS in the UK. And as you know, we as infectious disease docs oftentimes spend a lot of time talking to other providers about stopping antibiotics. We're like, you're using too many antibiotics, you don't have to use this. And then you go through this thing. It's like the risk of this is very low, and then blah, blah, blah. And the person's had a fever for 9 days and you've been on meropenem for 21 days. It's not the meropenem. So you try to reason through this. So in the UK, the UK Behavioral sort of Nudge Unit, which used to be associated with the NHS. Of course, the NHS is falling apart now, but they took a completely different tack. So they said, we want to influence providers to prescribe less antibiotics. And they looked across the entire UK, and they looked at the providers that were providing the top, who prescribe 20 in the top 20th percentile. So you prescribe more than your peers. And they sent you, because using sort of social norm theory, and particularly the idea that doctors are more or less sort of tribal in their behavior, they sent them letters from the NHS that said, you are in the top 20th percentile of prescribers of antibiotics in the UK. And this is how you compare to other practitioners that are like you in your geography and in your sort of specialty. They didn't go through and argue with like, okay, this guy's got CM, like you 21 days of meropenem is too much. And they just said, you are an outlier. And it reduced prescribing by millions and millions of antibiotic prescriptions in the UK. And they did it as a practice level randomized trial. So this is an example of how sort of centering the implementation problem and bring in a fund of knowledge about behavior change could lead to like important insights about advancing public health. And I think for that study, there are probably 24 implementation targets for that package of things. And they, in my view, they may not have studied all of them, but they could have at least identified 3 to 5 like high value questions in the implementation of these things, and then gone after them, conceptualized them, measured them, report them, and compare them across like treatment conditions. So that's, yeah, quick answer.
I think we'll have one more question from Judy, and then.
Thanks. Hi, Elvin. Thanks for your great talk. My question is a little also half baked, but I'm kind of thinking about, the money and thinking about new investigators. And maybe you have this in your training program, so maybe you have the answer. But in my mind, especially when I was a new investigator, and probably still, I think, okay, I can do a study where I know I can, recruit a bunch of patients and test a bunch of things and figure some stuff out on that level. And I think about going to the systems level and the menu systems, and I get terrified. And so I'm just sort of thinking about, are there approaches to get us in to ease the path of thinking on these other levels? Because I do think that our, knee-jerk reaction is thinking about the patient and the patient's families, and maybe we go up a few levels, but it's a lot harder to think about on the big levels when you're starting. So what is your advice for people starting, and kind of, where are the entry points that can make it easier?
Yeah. So that's a good question, and I have no answers baked or unbaked for it. But I think that it's a real and important problem, right? And I think as a scientific community, we have to solve that problem, because the implications of that is that like if science and scientific careers are made on answering certain types of questions, then scientific evidence will be restricted to like the questions that can be answered, not the questions that should be answered. And that is I don't know what the exit strategy is, but I think that that's a dangerous and unfortunate situation. And I'll give examples of this. I have a grant from the Gates Foundation to do evidence review to support sort of the WHO process. It's called the LIVE project. And we compile like the target of behavior change for implementation strategies and do it sort of systematically in the literature. Overwhelmingly, it's based on patients, right? It's like changing patient behavior. And there are less questions about changing the behavior of providers in the system because they're harder questions to ask. But I would say that like there are, give me 2 minutes to tell an anecdote and then maybe a potential solution, or, not a solution, but the issue of adolescent transition from adolescent pediatric clinics to adult clinics is a big issue globally, right? And a lot of people get lost to follow-up when they're transitioning. They go to this new clinic, it's an unwelcoming environment. And so there are a class of studies that are focused on training adolescents to be ready. Okay, so we're going to make you ready. We're going to educate you. We're going to prepare you. We're going to make you resilient. You go there, they're mean to you, you still go. We're going to focus on you. And that's not a bad thing. That's a good thing. But like, is that really where the levers of change can and should be focused scientifically? So I was involved in something that used human-centered design with adolescents to talk about retention, and in Kenya, and in that human-centered design process, which was not specifically about transition, but the issue of transition came up. They brought up potential solutions that looked very different. So they said, well, why can't you, first of all, they said, why can't you just keep us in the peds clinic forever? Okay, well, maybe that's not possible. But then they said, if you're going to transfer us, why don't you transfer us as a cluster? You know, so we go with our friends together and we go on a certain day, and we all go together so we don't feel intimidated when we go there. And then we can help each other get there. If you don't know how to get there, I can help you get there. And then they said, why don't you have somebody from the adult clinic come to our clinic and tell us about the adult clinic first, right? So these are all practical possible solutions to the transition problem, but they haven't been studied in randomized trials. Whereas the Get You Ready intervention has been now studied in randomized trials, right? So I don't know what the answer is, but there are methods, maybe like design and other things that can flip the script on what we should be doing, and help us get to a point where we can sort of try to make sure what we're doing is the best possible way to answer the question, rather than getting the best possible of the tractable ways to answer the question. I know that it's aspirational. It doesn't answer your question like at all. but actually, I have some thoughts maybe for that later as well. But anyway.
Well, thank you so much, Elvin. That was great. And I learned a lot. I think we all learned a lot. And today, Elvin's going to go around and meet with many of you in person. We have an early investigator lunch, and then some people are going to dinner. So if anyone wants to participate in any way, please let us know. And then otherwise, we're going to walk you over, Mallory and I,
Okay.
to Pride Hall, and that's where we're going to all meet with them. So thank you so much for being here.
Thanks.